This is kidney cancer, which is a common cancer, and it's associated with a high ratio of mortality. What that essentially means is that there are some cancers like skin cancer, breast cancer is another example, and prostate cancer, where the prevalence is quite high, but actually the proportion of patients who come into harm's way is relatively modest. One of the challenges with kidney cancer is because it tends to present quite late, because the kidney is buried inside the body, and the symptoms tend to be quite late. But when we diagnose kidney cancer, it can be often late, and therefore the mortality ratio is high. Let's move to the next slide. I'm going to, in light grey is clear cell. You can hardly see it. It accounts for 75% of kidney cancer, and it's what I'm going to talk about today. I'm very happy to take questions on non-clear cell kidney cancer. Papillary particularly, you'll be aware recently there's a study of cabozantinib versus sunitinib, which showed a progression-free survival advantage for cabozantinib. We've recently rewritten the European guidelines for papillary kidney cancer, and cabozantinib is given level 2B evidence, which is the strongest evidence we've ever given in this setting. And so I think that I'm very happy to take questions, but I'm going to focus on clear cell because it's the most of what we deal with. But I acknowledge that, and of course, I'm very happy to take questions on papillary kidney cancer, and it's a very real problem. Let's move to the next slide. So the one of the drivers of clear cell kidney cancer is around a very straightforward mutation to a specific gene, the VHL gene. If one develops mutations to VHL, it can result in upregulation of HIF. HIF accumulates. VHL is supposed to mop up HIF, and HIF is quite a powerful growth factor, which results in one of the consequences is upregulation of VEGF. And we know that VEGF is powerful in driving cell division and angiogenesis. There are other mechanisms and other mutations which some people say are relevant, such as AXL and MET, and even more recently FGF. And some of the drugs target those, but actually VHL, HIF, and VEGF is by far the most powerful driver for us. And we know like drugs like axitinib are very specific VEGF targeted therapies have never really been beaten as such. And so the role of these off-target effects beyond VEGF remain questionable. Let's move to the next slide.
Thanks. Tom, do you mind explaining what a VEGF is, please?
Yeah, so VHL is a gene, it's on DNA. And it results in transcription of proteins, and which occurs, and those proteins are associated with the development of and the integration of a string of other proteins. And VEGF is we also have genes for VEGF. But VEGF is vascular endothelial growth factor. It's a factor, and eventually it's a protein. And you have VEGF floating around in our blood. It's a normal growth factor, and indeed our cells, many of our normal cells, particularly our blood vessels, have receptors to VEGF. And so you can see in the middle of this big picture here, VEGF, the round orange blob, that would be a protein. And that would be in your circulation. And next to it is a V-shaped, and that V-shaped molecule is your VEGF receptor. And there are 3 VEGF receptors, VEGF1, VEGF2, and VEGF3. VEGF2 seems particularly important in this disease. And if you get or heaven forbid, if a mutation to VHL occurs, and there are some families that develop mutations to VHL, they're born with it, they inherit them, and they give it to generation. And those patients get abnormalities of blood vessel development, but they also get a predisposition to kidney cancer. So this VHL, HIF, VEGF axis is actually very important. You might say, what about if we looked or screened for VEGF mutations? Most of those mutations occur sporadically during our lives. Most are not inherited from our parents. They most frequently occur with time, and they occur commonly in the kidney when they occur with time. So those mutations accumulate, and that's why this is not a very heavily hereditary disease. Most kidney cancer is sporadic, and it's not relevant whether or not your father or mother had it. Now,
That's
clearly,
really interesting. Yeah.
clearly there are families where half the families have this VHL mutation, and that was why it was recognized, you know, von Hippel-Lindau, I think they're 3 German scientists from the 18th century or 19th century, because it was so obvious that something was going wrong in these families, because 50% of them were getting blood vessel development abnormalities. And so you didn't need any science to work out there was something wrong in these families with their blood vessels. But that condition is extremely rare. But the mutation in kidney cancer, which occurs with time and life, and some people seem to be more predisposed to it, that condition results ultimately in the development of kidney cancer.
Thank you. That's really interesting. And Tom, if you were worried that it is a genetic thing, what is the best way to get genetics looked at? Is it to go to your GP, or
yeah? So
I get asked a lot, and I never really know the best answer where to go.
I think people say that if you've got a VHL mutation in your family, you have a hereditary VHL, you would know about it, because you'll know your one side of your previous family will have been severely affected with blood vessel abnormalities, and they tend to get bleeding problems, and many patients get brain problems as well. So that's, you know, if you're worried that you might have a VHL family, don't be, because you would know it already. And those families are, but that's 0.1% of the problem.
Yes.
In terms of, are there other predispositions to kidney cancer? Well, you know, it's worth, people say, well, if you've got 2 members of a family, you know, under the age of a certain 50 or something along those lines, people say that you can go to a genetic counseling process, have genetic testing, and they're genetic centers, and they would go through the detail of your family and work out, you know, where things stand. It's quite difficult, because the question is, what do you do with the results?
Yes.
Because beyond VHL, which we know about, the other families, yes, they exist, but it's complicated to know what to do with the results. And if you were to have a family, you know, just having a father with prostate cancer and an auntie who was young with kidney cancer, those 2 are not related to each other. And so it has to be kidney cancer, the same cancer, and, you know, it has to be under a sort of an age probably of 50. And under those circumstances, it would be reasonable. We're not currently in a position where there's much that we do about it. You know, we don't have a blood test that can detect it, for example. Some people say, well, why not have annual ultrasound screening?
Yes.
And you might say, well, why not? Now, clearly, we can't do annual ultrasound screening of the whole of the UK population. But some people pursue that, particularly if they had a brother or sister who was young, just for peace of mind, and there's no harm associated with that. I wouldn't be having CT scans, because I think the radiation dose is probably not worth it.
Yeah, definitely. So Tom, we've got another 3 questions, if that's all right.
Fire away.
Okay, I'll start with one. And first of all, this is not a silly question at all to the patient who's written it. Is it possible to fix or edit the VHL gene? Yeah. And is it not? And if it's not possible, is it currently being worked on, please?
Yeah, so it is being worked on. There are techniques like CRISPR where you can edit genes, so it's possible. And we're working. I don't work on it. There are some brilliant scientists, much cleverer than myself, who are working on that, and progress is being made in that area. And it's a really important part of science. There's an ethical part to it as well. So what happens if we want to have our children want to have blue eyes or whatever it might be? Because can we edit those genes as well? So that this is and if you go on the internet and look up CRISPR, and you've got an evening to spare, you'll find a really exciting ethical and scientific debate. And I'm sure that there are some terrific podcasts on it as well.
Fantastic. I'm actually going to do that myself. I'm going to look that up. Another question, Tom, please. Could the blood issues included non-chaotic portal hypertension? And please say if you can't hear me very well as well.
So could the blood issues have be associated with portal hypertension?
That's it. Yes.
the blood issues per se won't be associated with portal hypertension, and portal hypertension in kidney cancer is relatively rare and would be a sign of probably more advanced sort of, dare I say, geographical anatomical disease. So if the cancer is getting large and blocking blood vessels, then you may get portal hypertension from there, and that would be associated with a large kidney mass rather than VEGF doing it specifically. And VEGF as a with its own right doesn't tend to cause hypertension. The hypertension tends to be caused by the drugs that we give, which cause vasoconstriction, and VEGF receptor antagonism causes that vasoconstriction.
Brilliant, thank you, Tom. And the last question was actually from a patient, Dave. Are you happy to talk? Because I think you've just put your hand up. Is that okay?
I'm happy to talk, but I didn't put my hand up. My apologies.
Oh, sorry, Dave.
Must have touched something.
That's fine, Dave. Did you want to ask anything, Dave?
No, I'm fine, thank you.
Well, thank you for listening.
Let's move to the next slide.
Yes, please. We're just doing it for you, Tom.
The second interplay, which I think is important, which I'm going to talk about now. This is a slightly complicated slide, slightly overcomplicated, and I apologize for that. I should have made a much more simple slide. What I was trying to say was there is an important interplay now between, we know the immune system has an important role to play in kidney cancer. It's not really well defined yet. Kidney cancer, when you cut kidney cancer out, you see that it has quite a unique immune infiltrate. The TME, and the top line here is targeting the TME, that's the tumor microenvironment. And when you look at kidney cancer cells, you see that there are a series of white cells, and the white cells designed to fight infection. There are a series of white cells that are associated with the cancer in the tumor microenvironment. And those white cells have a particular makeup, and many of those white cells come under a term of exhaustion. And what that means is those white cells are no longer functioning properly. And the cancer has, so the white cells come in to fight the cancer, they come in with good intention, but the cancer appears to have produced factors that make the white cells appear exhausted, and they don't work in the same way as when workers in a mine get exhausted, they don't work so well. And one of the markers of exhaustion, one of them is PD-L1. And another marker of exhaustion is CTLA-4. And there are other markers, LAG3, TIM3, and there are 10 or 15. And essentially, by inhibiting PD-L1 or PD-1 and CTLA-4, you reverse that process of T-cell exhaustion, and then the T-cells fight the cancer. And that's essentially, and it's a bit more complicated than that, but not much more complicated, speaking frankly. The T-cells are there in the cancer. You can see them under the microscope. And so the question is, what are they doing and why aren't they doing their job? And it's because the cancer cleverly has made them into an exhausted state. We've identified those markers of exhaustion, and now we can reverse those markers of exhaustion with drugs. And that is essentially how all of the immune therapies that we currently use work. They work in slightly different ways, and I'm happy to have a long discussion about the difference between PD-1, PD-L1, and CTLA-4, but you don't really need to know. What you need to know is the T cells are there, they're ready to go, but the cancer's tricked them and made them tired, and you can reverse that process. Are there any questions about the mechanisms of action of immune therapy? Should we keep going?
Please, Tom.
There are also other ways of targeting beyond the immune therapy. We've also learned ways of targeting that VHL axis. And actually, these three mechanisms are the same. There's also a new mechanism. You can target HIF directly. And I'm going to talk about that. It's currently experimental. We're doing a trial at our hospital at the moment, looking at HIF inhibitors. You remember there was VHL upregulation of HIF. Upregulation of HIF results in upregulation of VEGF. And you can block VEGF with the tyrosine kinase inhibitors, or with monoclonal antibodies. The tyrosine kinase inhibitors at the bottom prevent phosphorylation inside the cell. The antibodies take away VHL, like taking oxygen out of the air, and the mTOR, the final pathway, they inhibit way down the pathway. So you can target different parts of this axis. You can target VEGF, you can target with the receptor, you can target the tyrosine kinase, or you can target even further down using mTOR inhibition. But they're all essentially doing the same thing. And that is why when patients are given these drugs, you get the first one, it works well, then you get the second one and it works less well. And people say to me, why does the second one work less well? And it's not because the drug's not as good, it's because we're using the same mechanism, and the cancer has learnt other ways of overcoming that mechanism. Some people say that drugs like cabozantinib and lenvatinib that have parallel other mechanisms of action, such as AXL, FGF, the reason why they work better in resistant disease is they're targeting parallel pathways. That's never actually been proven. And I suspect there's a degree of marketing in that, to be honest, because axitinib is a pretty good second-line drug, and yet that doesn't target anything except VEGF.
Thank you. Tom, can I ask, if you're not on a trial and you really want a trial, but you don't know the best way to get an opportunity to see if you're eligible for a trial, is there a best way of doing it? Because obviously you do incredible trials at your hospital, but for someone that isn't on a trial, wants to see if they're even eligible, is there a good route to get on one?
No, we can talk about that at the end. I'd be very happy to send you a list of all of our studies, and you can broadcast them as much as freely as you want to.
Oh, Tom, that would be wonderful.
We'd really like to do that. I mean, I think that one of the we'd love to do that. I mean, it would really help. Over the last 10 years, or 5 years particularly, while there's been a transformation in the treatment of kidney cancer, we've got a whole group of patients from our clinic, because we've been using these drugs for, we were involved in the original Ipi-Nivo trials 7 or 8 years ago. We've got a whole, and the Bevatezo trials before that even. We've got a whole room full of people who, who took part in these trials, got early immune therapy, and have done really well. So, we'd love to help if we can. This is a complex slide. Basically, all you need to know is they're different VEGF targeted therapies. The top line is the only important line, really. Maybe the second one too. As you can see, some of them are dirtier than others. I've not included sunitinib up here. Sunitinib is not that dissimilar to cabozantinib in many ways, except the AXL and MET. The reason I've got axitinib up here is axitinib has a really short half-life. And that's quite attractive, because if you're giving drugs in combination, it's good to have a drug that can get out of your system really quickly. And I put lenvatinib up here because it's new and people keep asking me about it. So, frontline cabozantinib, frontline sunitinib and pazopanib is a bit old-fashioned now. Now we're giving combinations, and actually the combinations are based on these 3 drugs, not on sunitinib and pazopanib anymore, which is another reason I haven't shown it. And that's what the bottom half of this trial shows, the IO trial partners. And I'm going to describe all of these studies to you now. Let's move to the next slide. So there's this early stage disease, operable disease, and then there's advanced disease where the cancer spread. And there is quite a clear definition between the two, speaking frankly. In urothelial cancer, which I also treat, many patients, we're not really sure if they've got advanced disease. And this, to some extent, applies in kidney cancer. But actually, there are no perioperative treatments. So at the moment, you either have your kidney removed for cancer or you don't. And there are different techniques to have your kidney removed. I'm not going to go into huge detail at the moment. Laparoscopic partial nephrectomy is currently popular. They're not randomized data to support it, but it looks like your time in hospital is less, and most people feel that keeping part of your kidney is attractive. Total nephrectomy is an alternative, and there isn't that much data to suggest it's the wrong thing to do. I'm going to talk right at the end about adjuvant studies, but let's just talk about advanced disease. So if we move to the next slide. This is the IMDC prognostic criteria. Kidney cancer tends to spread to the following areas. Lymph nodes, number 1. lungs number 2, bone, liver, brain. There are some other areas such as thyroid and pancreas metastasis. Patients with those areas do very well. And of course, they're rare and wonderful metastasis to the stomach and other areas. But as a rule, lymph nodes, lung, commonest, liver, bone, brain in those areas. Should we be doing brain scans at baseline? I think patients should have a baseline brain scan before we start systemic therapy. Some people disagree with me. The CT scan takes 10 seconds to go up a bit higher. And, you know, having brain metastasis does complicate things. I know there are questions about SABR. One of the areas where I'm supportive of SABR, one of the few areas, is in brain metastasis. I'm not supportive of whole brain radiation. I don't think it works. I don't think it's helpful. I think it's counterproductive. But SABR is important, so we should go up to the top, in my opinion, and we should be prognosticating patients into favourable, intermediate, and poor risk disease. It's basically based around a blood test. So your full blood count, it takes 20 seconds to do. Everyone should have it. If you have favourable risk disease, your treatment's slightly different, actually, because ipilimumab and nivolumab doesn't work well in favourable risk disease. Intermediate and poor risk disease treatment, again, is a combination. It's then either VEGF TKI plus immune therapy, or it's immune therapy. Whereas favourable risk, there's a debate going on about the right treatment. And I'll try and have that debate with you today. Let's move to the next.
Tom, so can you just explain what SABR is, please, to some of the patients, please?
Yeah, it's stereotactic radiation therapy. So it's shining very bright X-rays at specific areas. And in the past, we've been less good at targeted radiation therapy. And that's why whole brain radiation was given, where you zap the whole brain. It makes you feel really tired. Now, you get an X-ray gun, and that X-ray gun fires really bright X-rays directly at the cancer, zaps it. And the problem with SABR as it currently stands is it's been adopted by clinical practice in kidney cancer without really any data. There are some small phase 2 trials, and I was, you know, and I'm broadly supportive of the principle. But remember, radiation therapy's not worked well in kidney cancer historically. The thing that's changed outcomes for patients is not surgery. And the things that change outcomes of patients is not better diagnostics. And it's not radiation therapy. The thing that's changed the outcome of patients over the last 7 years is the development of targeted therapies. And my concern around surgery and radiation is that we've had those for a period of time. We haven't got randomized data to support their use. And therefore, using more and more because the targeted therapies and the immune therapies work well doesn't necessarily mean that SABR suddenly works well too, or indeed nephrectomy is better. So I'm not a great believer. There are people who disagree with me, but and I'm happy to have that debate. But I tend to win that debate because, and I lose a lot of debates in my life, and I'm very happy to lose debates. It's the best way to be. If you win 50%, you're doing okay. The reason why this is an area I tend to win is because in the end, I say, show me the data. And then there's a silence. And they say, no, I've got a patient who, and we've all got a patient who did well, but we haven't seen those prospective studies that show it's better than not doing it. And if you're going to interrupt systemic therapy, or you're going to do a procedure, you have to show clear benefit. Otherwise, what's the difference between that and cannabis oil? And if you had a radiation doctor here as it currently stands, they'd say, well, tell me how we are doing that work and we get it. And I say, fantastic, let's get them to do it together and I'll support that and I'll take part in those trials. But let's do those trials.
Yes.
Should we move to the next slide?
Yes. Can I just ask you a question, Tom, please?
Yes,
Is SABR useful for distinct singular tumours rather than extensive brain tumours?
SABR is only useful for distinct tumours. So absolutely. So what, an area where I might use SABR or might use SABR would be, let's say we had a 75-year-old patient with metastatic kidney cancer who was well. I gave them ipilimumab and nivolumab first-line therapy. With intermediate risk disease. They had a great response to all of their areas in the lung and in their lymph nodes, but they developed one new lymph node that showed progression of disease. And that one area, you might say, this defines treatment failure. And I might come back and say, well, hold on a second. What about if we zap that one area with SABRE and then we continue? Now, there are people who'll say, wait, Tom, that one area, that is the canary in the mine. And what will happen is there'll be lots of different areas on the next scan. And you might even miss the boat back to switching to VEGF targeted therapy. And so you're better off switching to axitinib or cabozantinib than actually giving SABRE under those circumstances. And if the relapse happened early, so if it all happened within the first 6 months of treatment, I would probably agree. But if we're 2 years down the line, having done exceptionally well and had an almost complete response to ipi/nivo with one area left over, I think SABRE would be an attractive option under those circumstances. So that's kind of where I am with SABRE at the moment without more evidence to support it. Let's keep going. One of the questions which I'm frequently asked is patients with metastatic disease who have been diagnosed with hematuria, for example, and weight loss, and their kidney is still in situ, so they have not had their kidney removed. Should those patients have a nephrectomy? It is counterintuitive to perform ultimately patients succumb to metastatic disease, not to disease coming from the kidney. It is counterintuitive, therefore, for the when we have a series of good treatments to control the life-threatening metastatic disease, for the first thing to do is to remove the kidney. We did a randomized trial of nephrectomy followed by sunitinib versus sunitinib alone to answer this question. The UK took part, we didn't recruit well, which was disappointing, but the French did recruit well into this trial. And if we move to the next slide, this is a Kaplan-Meier curve, and Kaplan-Meier curves look at outcome, and essentially everyone starts at 100, and you can see months at the bottom, and you would hope, and I would hope, that everyone on this call is going to be alive for the next 5 years. That means at 60 months, that 100% would continue, and it would be a flat line. We know cancer patients don't live unlimited periods of time, and some succumb of their disease. And you can see both of these curves dropping with time. And the question is, which curve drops the quickest? And you can see here the nephrectomy alone arm, or the nephrectomy and sunitinib arm, is blue, and that drops a bit quicker than sunitinib alone. And what that's telling us is the combination of surgery with sunitinib is a little bit less good than giving sunitinib alone. And that's telling us that in some patients, nephrectomy is probably harmful. This has changed our thinking a little bit, because historically, when we had very few active treatments, we said, well, at least we can remove the kidney. But this is a change, and there are still surgical communities. And again, I have this debate a lot, and I normally win this debate. I'm showing the debates I win today. I'll show you some I'm losing in a second. But if you present with metastatic disease, the right thing to do is to see an oncologist, to have a multidisciplinary discussion, and not have a nephrectomy unless there's a very good reason to have it. Now, nephrectomy in early disease, in non-metastatic disease, of course, is standard of care. But in metastatic disease, when the cancer spread to the lungs or other areas, think very carefully before giving a nephrectomy. And the reason why is the blue line drops faster than the red line. And the reason it drops faster is because when you give drugs like sunitinib or oxypembro or ipi/nivo, you get rapid control of disease. If you do a nephrectomy first, it takes 4 weeks to have a nephrectomy and 6 weeks to recover from it. And during that time, cancer will grow.
Tommy's got a quick question. What are some of the factors that would lead you to not have a nephrectomy versus having one? I mean, in specific, a patient rather than factors based on studies.
So I think if a big bulk of the cancer is in the primary kidney, number one. Number two is if the metastatic burden is very low. So let's say 2 lung metastases, both less than a centimetre, and a 10 centimetre kidney cancer. That would be a good candidate for a nephrectomy. Let's take the other example where a 3 centimetre kidney cancer and big liver metastasis. That patient should definitely not have a nephrectomy. And actually it's not hard, and I reckon about 20% of patients should have a nephrectomy. So this is a classic study. This is showing pembrolizumab and axitinib versus sunitinib. Pembrolizumab is a PD-1 inhibitor. It's a well-known PD-1 inhibitor. Remember the immune therapy that re-educates the immune system, reverse that exhaustion process. Axitinib, a very good VEGF targeted therapy. Sunitinib was the frontline standard of care. Let's move to the next slide. And here, this is overall survival, and you can see here the sunitinib curve is dropping faster than the pembrolizumab and axitinib curve, suggesting patients are coming into harm's way quicker with sunitinib, and therefore pembrolizumab and axitinib became a standard of care based on this. The combination is relatively well tolerated. It's not worse tolerated than sunitinib. It's more difficult for doctors to give, and clearly it's more expensive as well. It's more difficult for doctors to give because 1 in 10 patients get into harm's way with immune therapy. Harm's way looks like the following. You can get activation of the immune system, which fights your own cells. And that can involve toxicity in the lungs. It can involve toxicity in the kidneys and the liver. It can cause skin toxicity. It can cause nerve toxicity. And all of these events, and in fact, it can cause inflammation of pretty much anything you want. You can reverse it quickly with steroids. But because the array of symptoms are so diverse, there is a genuine clinical skill in working out if it's immune-related toxicity or not. And so when a patient comes in with a bit of shortness of breath, in years gone by, we just say, oh, that's probably just a cancer. Let's see how we go. We'll do a CT scan in a few weeks. If a pembrolizumab patient comes in with shortness of breath, you have to assume, till proven otherwise, that it might be fibrosis of the lungs associated with the immune drugs. You need to do CT scans and oxygen tests, and you may need to start steroids and temporarily halt the drugs. That's quite a clinical skill, and therefore giving immune combination therapy is more difficult than it used to be. And one of the most important questions which I'm going to get asked is which is the best combination? And actually my message is very simple. There are more similarities than differences between the combinations. The big difference is not in the drug name, but in the skill in the clinical team and the support network in the ability to give the drug. You need to have good nursing support with a CNS. You need to have a 24-hour hotline number that you can call if you get into harm's way. You need to be seen every 3 weeks for the first 12 to 18 weeks. You need to have a medical team that's had experience of giving these drugs. Data out of the United States of America at the moment is suggesting that that actually patients, instead of getting the normal, in the trials, we gave 11 months of therapy median. It looks like we're giving much shorter than that in the real world. And that's an experience issue that we need to resolve. Let's move to the next slide. This is a Javelin 100. This is axitinib and nivolumab, and this is really complicated. Nivolumab is not a PD-1 inhibitor, it's a PD-L1 inhibitor. I said the drugs had more similarities than differences, and that's true. But if we move to the next slide, you can see here that actually the survival of the two are very similar to each other. The sunitinib is not actually dropping much quicker than the nivolumab. There's not much difference between the two. And this trial was not statistically significant. The irony is that NICE has approved axitinib and nivolumab, which is going to be more toxic than sunitinib, more expensive and more difficult to give without a survival advantage, and rejected axitinib and pembrolizumab, which has that survival advantage. I am not involved in those decisions, and other people more worthy than myself are, but there is a question to be asked here. I do not routinely give axitinib and nivolumab to any patients. It does not have a survival advantage. It's not recommended by the European guidelines. And irrespective of the price, If it's not better than sunitinib, why not just give sunitinib? Let's move to the next slide.
Thank you. Tom, can I ask a couple of questions? Is that all right?
Yeah.
I'm currently on third line treatment for metastatic. Sometimes it feels like my options may be running out in terms of treatments. Have there been any more developments in fourth line on further treatments which could be available either on the NHS or private? Please?
I'm coming to it. Can I answer that question in 30
Of course
seconds?
you can. I apologise.
Yeah, okay. So let's move to the next slide. And this is the latest study. The light grey blocks, I apologise, that's pembrolizumab, the PD-1 plus lenvatinib. Now you might say, Tom, I'm getting bored of this because we're hearing the same combinations again and again. And actually we can move to the next slide. That's the PFS, which is impressive. So much longer progression-free survival. And this is data's quite striking. So this is not overall survival. This is progression. This is time for the cancer to grow. And that 0.39 is much, you know, that's a 60% reduction in progression. This is probably the best data we've ever seen in kidney cancer. So sunitinib, which 5 years ago we thought would be really hard to beat, and this is a 60% reduction in progression for lenvatinib and pembrolizumab. This is currently being assessed by the EMA and the FDA, and it looks like a good combination. If we move to the next slide, the overall survival, again, like the axitinib and pembrolizumab, but not like the axitinib and nivolumab. Remember, it's pembrolizumab again. It's the PD-1 inhibitor, not the PD-L1 inhibitor. And this is statistically significant. You can see the curves going apart here. So now I've given you two choices, axi-pembro, lenvatinib pembrolizumab. Let's move to the next slide. And the last combination is cabozantinib and everolimus. Sorry, cabozantinib and nivolumab. And so I've shown you axi-pembro, which was positive. I've shown you lenvat-pembro, which was positive. Now, nivolumab is another PD-1 inhibitor, not PD-L1. And let's go to the next slide. And you can see this also has a survival advantage. You might come to me and say, Tom, what are the subtle differences between these four combinations? And I can describe them in broad terms today, but each of these combinations with the PD-1 inhibitor, nivolumab, cabozantinib, len-pen, axi-pembro. We did a podcast on this. We do something called Euromigos podcast. A group of us do it together. We're a group of friends. And we took a debate. We had a debate. You can find them online. And we had a debate. A guy from the ND Anderson picked len-pen. Brian Rinnie picked axi-pembro. I took on cabo-nivo. And you can have a very reasonable debate for all three. It's much harder to argue for axitinib-nivolumab. Remember, that didn't have a survival advantage. And no one wants to take that debate on. Because without survival, you don't get in the game. But with survival, each of these regimes have attractive features. Axitinib has a short half-life and is the easiest to manage. Lenvatinib pembrolizumab had that brilliant progression-free survival data. Cabo-nivo, well, everyone loves nivo and everyone loves cabo. Why not give them together? So each of them have arguments. It comes back to the point. Don't get sucked into that debate. It's all about, does the team know how to do it? Do I have 24-hour support? That's what's important for patients. And so this is the second approach. The second approach is, what about giving two of those drugs together, which re-educate the immune system, and leave the VEGF TKI therapy for the future? I was involved in this trial, and I was always nervous because I thought sunitinib is going to be great at the start of the journey, and it's going to be hard to beat. I knew the immune therapy would win in the end because the immune therapy has long-term durable remissions and sunitinib doesn't do that. But I was worried that what they won on the swings, they would lose on the roundabouts, and that ipi-nivo wouldn't be good at initial control. Let's move to the next slide. This is data in only those intermediate and poor risk patients. Remember, I showed you that in the good risk patients, in the favorable risk patients, ipi-nivo did not work well. And the reason why that's the case is sunitinib is really good in the good risk patients because they're very strongly driven by VEGF. The really striking feature of this curve here, this first one is a progression-free survival curve. That means the drug is still working. The curves I've been showing you up to date are overall survival curves, and the bottom one is overall survival, and you can see that's significant. The orange ipi-nivo is outperforming the grey sunitinib. But the top curve is important, because you can see here, 30% of patients after 5 years are still on first-line therapy. Their first-line treatment is still working. If you go back 5 years, median overall survival for patients was only 2 years. And here, the first-line treatment is still working in 30% of patients at 5 years. This is transformative for that reason. The problem with ipi-nivo is it's less good than axi-pembro, len-pen, and cabo-nivo at getting initial control of disease. The response rate for this combination is 40%, where the response rate for len-pen is 70%. And I tend to pick VEGF-TKI immune combinations because I think they will show the same tail of the curve, the same long-term results, but I think we will lose fewer patients up front by giving the combination together. When I give ipi-nivo to patients, and I give quite a lot in the UK, because we don't have access to axi-pembro, we don't have access to len-pen, and we don't have access to cabo-nivo, so I give ipi-nivo, and what I see is many patients just progress through, and we have to switch quickly to second-line therapy. And that's why currently my preference would be to give, for example, axi-pembro. Let's move to the next slide.
Can I just ask you a question, please,
Yes,
Tom? I'm on cabo second-line treatment. I've been told that nivo is my next option. Should that actually be nivo, or could it be should it be cabo plus nivo, or just nivo alone?
That's a really excellent question, and the answer takes about half an hour. But I'm going to call it. But I'm actually, it's either two answers. Listen, we don't know the answer to that question as it currently stands. There is currently no data for cabo-nivo after cabo, or indeed after any first-line single-agent therapy. So giving second-line or third-line nivolumab to individuals who have previously had VEGF-targeted therapy is the standard of care globally, and any combination beyond that is experimental. You should have immune therapy next, and nivolumab is the right treatment. There is some data for ipi-nivo in that population. It's retrospective, it's not very good, and it doesn't look fantastic. And I wouldn't be giving that in front of nivo as it currently stands, personally. Although some of my friends in America like to say, we're just going to give everything and see what happens. I'm not supportive of that. It's like the SABRE debate. Without the data, why do we support it? Well, we think it might be better. Yeah, it might be worse because of the toxicity. Cabo-nivo, giving VEGF-TKI plus immune therapy is the next therapy. I actually think giving a clean break, stopping the VEGF-TKI and giving single-agent immune therapy, for me, makes a lot of sense, particularly if you've had 2 previous VEGF-targeted therapies. And I assume this individual had sunitinib first, then cabo, and now being offered nivo. And I think that's entirely reasonable. It might be worth looking to see if there are some immune therapy trials, because there may be some new immune combinations being prospectively tested, which I think is reasonable. I can see here it was pazopanib, then cabo, entirely reasonable. My preference is, for what it's worth, pazopanib I think is a better drug than sunitinib. It's slightly better tolerated, but I'm not getting into that debate. I'm very happy with sunitinib. So I think they're equivalent drugs. So I think nivo is an entirely reasonable choice under those circumstances, and what I would do. Anything other than that would be experimental. And my preference would be to switch sooner rather than later. I wouldn't wait for lots and lots of progression. I would switch at first progression. And the reason why that's the case is I think slightly earlier immune therapy is probably better, in my opinion.
Thank you, Tom. And there's another question. These are all new promising first-line treatments. What about second-line and beyond those who are already metastatic?
So I'm going to come to that question in a minute, and I've got a slide on that question. We've got into a mess in second-line therapy because we've had this seismic change in front-line therapy. What do you do next? because all of the previous second-line therapies were dependent on getting sunitinib first, but we're not giving sunitinib first anymore. And it takes 5 years to do trials. And we didn't know the frontline trials were going to be positive, so why would you do a second-line trial if you don't know first-line therapy is going to change? So actually, what happens in this field is first-line therapy changes, and then we do second and then third. Now, some people might say to me, well, Tom, wait a second. You've got data. You're not happy to give Sabre because there's no data, but you are happy to sequence VEGF targeted therapy. But remember, those VEGF targeted therapies have been proven in randomized trials to be better than doing nothing. So we have some data, although it doesn't fit exactly. And so we are driven by data that we know that is not necessarily perfect. And my preference, for example, post-ipi-nivo would be to give a VEGF TKI. Many people would say cabozantinib is the right VEGF TKI. I actually don't feel strongly about it. Post-ipi-nivo, I tend to start again, go sunitinib, and then cabozantinib for what it's worth. I wouldn't re-challenge with immune therapy. Post-axi-pembro, I would give cabozantinib. Post-cabo-nivo, I would give axitinib. Post-lenvatinib pembrolizumab, I would give cabozantinib or axitinib, or even sunitinib. So there isn't huge science behind it. And as I said before, there are more similarities than differences between the drugs. Should we move to the next slide? So the other thing about the ipi-nivo data is we've looked at quality of life. These are patient-reported outcomes. Patients are asked 19 questions about their quality of life at regular time intervals. You compare sunitinib with ipilimumab and nivolumab. 0 is baseline. If it goes above 0, you're feeling a bit better. If it goes below 0, you're feeling a bit worse. And the key here is that you can see ipi-nivo drifting in an upward direction, whereas sunitinib takes a dip and stays a bit lower. And I think this is entirely reasonable. Ipi-nivo, the toxicity is pretty challenging for the first 12 weeks, speaking frankly. Most patients have a problem of some description, and you need to have a really good medical team for that. Once you've got through that first 12 weeks, it's then actually relatively straightforward, ipilimumab and nivolumab, because you're giving single agent nivolumab, whereas sunitinib has the long-term toxicity of VEGF TKI, the change in taste, the fatigue, chronic diarrhea, sore hands, sore feet, sore mouth. So, this is quite an important factor. Long-term, live longer, feel better, durable remissions. Let's take those 2 questions.
Sorry, you got 5 questions, Tom.
Let's have a go at those 5 questions.
Right, I'll start at the top. If looking for an experimental combination of immunotherapy, following sunitinib first and then lenvatinib and everolimus second, what is available and reasonable?
Well, immune therapy sounds good. So the first was sunitinib, the second was len-everolimus. I've not talked much about len-everolimus. Len-everolimus is a combination which was in the CLEAR trial. It doesn't look to be clearly better than cabozantinib or axitinib. And my point is, why give 2 drugs when you can give 1? You're going to get more toxicity with the 2 inevitably. And we know that lenvatinib, the toxicity of lenvatinib is quite complicated because it's given at different doses. And I don't want to give you a long discussion around dosing of lenvatinib. But as it currently stands, I kind of like lenvatinib pembrolizumab because the data is super cool. But len-everolimus, I look at it and I think, you're giving more drugs and they may or may not be better. So I'm a bit grayer about that. What would I do in this current individual? Well, there's a study at Barts at the moment looking at a HIF inhibitor, which I'll talk about in a second, versus everolimus. They wouldn't be eligible for that because they've already had the everolimus. But there's the whole immune therapy category which hasn't been explored properly. And currently, single agent nivolumab would make a lot of sense because they've not had an immune therapy. And also there are immune therapy trials that we hope are going to open soon, looking at different immune combinations. And I think they would be quite attractive. So, I think that for this particular individual, there is this whole unknown about how they're going to get on with immune therapy. And again, my preference would be to start immune therapy sooner rather than later. Wait for, of course, let's hope progression never occurs. Heaven forbid if it does, I wouldn't treat a long way past progression. I would switch to immune therapy sooner rather than later. Which was the next question?
Okay, is there any difference regarding the location of the mets, i.e. minor or bone mets?
Yeah, I mean, I think that in terms of outcome, the best site is pancreas, then thyroid, then lymph node, then lung, then bone, then liver, then brain, in that order. The more different sites you have will always be driven by the worst. So if you've got a pancreas metastasis, which is the best, and a liver metastasis, that you become a liver, that will be driven by that liver group. And the sites of the metastasis in combination with the IMDC score can give you some indication of how serious the cancer is.
Perfect, thank you. Next question, Tom. Sunitinib didn't agree with me. I ended up in hospital, being on 20 milligrams of Pazo for 4 years. Last scan showed growth. My only kidney, which has the primary and stable in the 4 Met, is in my pancreas. What are the chances of immunotherapy not agreeing with me, like sunitinib?
I mean, the first question I'd ask is if it's only progressing in the primary cancer and it's been 4 years, what about removing that and doing an nephrectomy at this point? So that's the first question that I would ask. And the second question, that's the first question. I think, if there is progression in that area and it's been 4 years, I would be thinking, if it was 1 year, I'd say switch. But if it's 4 years, I would be asking about nephrectomy. Yes, of course, have a go at immunotherapy, and I think it will work because we know that patients who have been on treatment for that long period of time tend to do well with immunotherapy. But I'd be asking the first question about saying, if this is the only site of progression and the other sites have been stable for 4 years, let's address this primary site.
Perfect, thank you. Next question. What is your view on the temporary NICE COVID changes, i.e. first line oral based and allowing IPI as second line to reduce hospital visits?
I think we need to move on now from COVID. We have cancer patients should be vaccinated. If they haven't, they should go out and get those vaccines, number one. Number two is, in our hospital, we haven't had a COVID case now for a month. We, during the second wave, I don't think we had an increase. We did not have increased mortality in our cancer hospital associated with COVID. That doesn't mean people, in our community were not affected by it, but we didn't, unlike the first wave where we did have cancer deaths, we constructed hospitals that are safe, getting patients to screen and avoid A&E departments. We're now vaccinated. So I just think we need to go back to where we were before. And I don't mind giving, there's no evidence of giving. Let me tell you what I think.
Go for it, Tom.
I don't think those emergency guidelines were a bad idea because of the uncertainty last March. I think right now they don't have a place because we've moved on. If you said to me, I want ipi/nivo after sunitinib because I didn't get it to start with because of COVID, I'd come back to you and say, well, there's no data on that. So you can have it, but why are you assuming it's better? What about ipi/nivo and axitinib? Why not take the 3 drugs on that principle? There's no evidence that 2 is better than 1 as it currently stands. So why not give all 3? There's no logic behind it. You're going to get more toxicity. So I don't really understand the principle that more is better, particularly with ipi/nivo, where we know the first 12 weeks are really tough. And so where I am currently with this, by the way, we know ipi/nivo is most active in specific types of cancer. And we know sunitinib changes the gene expression of the cancer. And so therefore we've got no evidence that CTLA-4 is active. We should do the trials. I'd like to do the trials. So that's how I feel about those guidelines. I think we just need to get back to a new normal as quickly as possible. And part of that new normal is treating kidney cancer patients in a normal way. And frontline sunitinib with ipi/nivo on our back pocket is not a good strategy as it currently stands. Now, if you've had sunitinib frontline and you want to have a discussion about whether you should have ipi/nivo second line because of that, I'm very happy to have that discussion and that debate. And if someone wants to have that discussion with me, I'm happy to do that.
Brilliant, thank you, Tom. And another question. I've had sunitinib, ipi/nivo and cabo. What would be my next treatment in your opinion when my cabo stops working? I've got multiple lung mets and a single liver met.
Okay, so there is a trial out there with HIF, which I'm going to talk about in a second, versus everolimus. And that's probably what I would do.
Okay, perfect. Thank you. I'm just checking, Tom. I haven't missed any questions. Okay, I have missed one. I apologise. How does sunitinib change the gene expression of the cancer?
I've done a lot of work on that in my life, and I'm probably so the first thing I think that's relevant is sunitinib results in upregulation of PDL1. So it increases the expression of the immune biomarkers. That's not necessarily a good thing, because you remember those are biomarkers of exhaustion, of T-cell exhaustion. So although you say, oh, it's gone up and that's good because we've got a target to it, that's not necessarily a good answer, because upregulation of bad factors, even if you target them, when you do target them, it just makes that bad factor less bad. So sunitinib is associated with dynamic changes to immune biomarkers, number one. Number two, sunitinib is also associated with, and there's a debate about this, about clonal heterogeneity. So it's developing new mutations on sunitinib. The tumor becomes under, like COVID, it comes under pressure. The vaccines will put COVID under pressure and mutations will occur. If you give sunitinib, there's vasoconstriction, but some of the clones will be resistant to that and they will then grow more quickly. So you get dynamic changes to gene expression, and those genes, some of them will be associated with resistance to both immune therapy and to VEGF targeted therapy. And ultimately, that's why the treatment fails, is because unlike immune therapy that re-educates the immune system to fight the cancer in the long term, drugs like sunitinib and axitinib, they put the cancer into a state of shock, they don't get rid of it completely, and those cancer cells left behind sit dormant, find a way around the problem, and then regrow. There is a new target as well. So the one question I'm interested in is the triplet, Cabo, Ipi, Nivo, and then this is HIF. Right at the beginning of the talk, I talked about actually VHL and HIF being related to one another, and a HIF then going to VEGF, and currently we're targeting VEGF. HIF is the intermediate step, it's a transcription factor, and it's crucial in that process. Let's move to the next slide. And if you target those patients that have a VHL mutation, right at the beginning, I said VHL mutation, there's a group of family of people, those families know who they are because 50% of those patients have got significant problems associated with it. And those patients get renal masses. If you target those renal masses with this HIF inhibitor, MK6482, you get this very high response rate. This is really interesting and important for those patients because I suspect this will get approved as a treatment, because at the moment they just have multiple kidney operations and eventually go into renal failure. So this is, I think this is practice changing for that small group of patients. But what does it mean in kidney cancer, in clear cell metastatic kidney cancer? Let's move to the next slide. And this is a phase 2 patient study of, so an initial study that has led to randomized trials that are ongoing. And you can see here response rates of 25%, progression-free survival of 15 months. This drug looks like a new exciting drug. Its toxicity profile is different from VEGF targeted therapy. No sore mouth, no change in taste, less lethargy, no hand and foot syndrome, no stomatitis, some anemia and some fatigue, but not as significant. Now you might say this all sounds too good to be true. And it probably is in the following. Number one is the mechanism of action is likely to be similar to sunitinib. So it's unlikely that it will replace or beat sunitinib. It might add on to sunitinib. And so combination trials are really important. And it will be an attractive alternative in the third line setting to drugs like axitinib or sorafenib or other drugs we've given. But it is a very exciting drug for the future. And we are hoping to do frontline trials of ipilimumab, nivolumab, and this HIF inhibitor, for example. I'd love to do that study, and trials along those lines for the future. And so this is one aspect of the future. And I think this is the last slide which I wanted to talk about. So just to summarize what I've said today, the biology of kidney cancer is well defined and we're targeting it well. We haven't yet personalized therapy around biomarkers. And that's partly because most cancers, or most clear cell kidney cancers, are reliant on this immune confusion, immune exhaustion, and VEGF mutations or VEGF overexpression. We've developed a series of drugs that have now superseded sunitinib and pazopanib frontline, which is really exciting, but they have to be based on PD-1 inhibition and not PD-L1 inhibition. And therefore, they're in the UK, where we give axivalimab, that needs to be questioned. An alternative is to give immune-immune combinations with ipilimumab and nivolumab, all of which have similar outcome data. The debate about which drug combination will go on, but it's not the most important thing for patients. The most important thing from patients is, am I in an experienced centre with 24-hour care and good nursing support? If you tick those 3 boxes and you're getting a combination, it doesn't matter which one you're getting. And if you're not getting that, you're better going to a hospital that can do that.
So if you're in that situation and you wanted to go to say a bigger centre, for example, is the best way to get a referral for your present consultant or medical team?
Yeah, I think we're in an environment where it's very reasonable and actively encouraged. And you don't need to come to Barts. We've got lots of patients, and I'm not suggesting, I don't want anyone to come and see us who doesn't want to come and see us, and I don't want to undermine other people's practices, and I don't want to say that anyone else is doing a bad job. You know, none of that is what is my ambition. My ambition is for a patient to go to a medical team, wherever it may be, including ours, to be confident that the medical service is robust, to ask, have you treated these combinations before and how many? To say, do you have audit data? So can you reproduce what does your results look like? I would love patients to go to their doctors and say, okay, you're offering me a treatment. Have you treated this before? What does your audit data look like? Have you, can you reproduce? Do I have a 24-hour nurse support team? Do I have a nursing team? These are the questions patients should be asking, not which is the best combination. And if you're not getting the answer of yes, yes, yes to those, then you need to say, I'd like to go and speak to someone else who might have those for me. And that process should happen quickly. And it has to happen quickly. And even if it means starting a regime somewhere and moving somewhere else to get it in the future, that's a discussion, a debate. I'd be much happier, but I'd be much happier to start in the right place at the right time. I think that's really, starting the journey in the right place at the right time is really important. And yeah, so going and saying I want to be seen by a big cancer centre. I'm not going to name names, but clearly they're dotted through the country and we know who they are. Most patients have faith in their doctors, but it is very reasonable to ask the question about, is this something you do regularly? Have you got audit data? Do I have a 24-hour support line? Do I have a CNS? Because you don't have those 3 or 4 things are more tricky. And the choice of the drug is irrelevant under those circumstances. Cabo-Nivo, Ipi-Nivo, Axi-Pembro, Len-Pen, all are fine.
Thank you. Can I ask you another question, Tom?
Yes, of course.
Thank you. Are there any geographical implications with trials? I live in Northern Ireland and I feel I don't have access to as many trials as others have in mainland Great Britain. Is there an option for teams to work cross-functionally across the UK or for remote trial participation?
So remote trial participation is really hard for interventional studies because you have to see the patient in front of you, and that's one of the requirements, which is difficult. I think that we have had issues in Northern Ireland with trials, and I know the group in Northern Ireland is working really hard to build a successful cancer centre, and they've contacted me around that, and the people there are fantastic. The hospitals need to get selected to take part in trials, and you need to build up a track record to get the latest drugs. I think it would be fantastic if in Northern Ireland, and Scotland clearly has the Beatson, and Cardiff is a terrific centre, and Valindra and other centres in Wales, really strong. I'm not sure we're nailing kidney cancer trials in the UK as well as we were 5 or 10 years ago. I think some of the funding associated with trial nurses has reduced, and support for trials has reduced in the NHS recently. And we recruit less well than some of our European competitors than we did before. And this is a problem. And one of the things I'm saying we recruit trials at Barts and we're comfortable, and I know I don't need more patients, and you know, this is not a land grab, what I'd like to see is the UK with a really strong Northern Ireland Cancer Centre where patients can take part there, and that cancer centre is being regularly selected for trials. And one of the questions that the patient groups need to ask is, why is there heterogeneity of trial availability? And this won't be just in kidney cancer in Northern Ireland, it'll be in all cancers. And the actually investing in clinical trials ends up being financially lucrative for that centre, because trials are funded, you get the drugs free, you get the nursing costs are covered. So ultimately, it's the right thing to do, but it's difficult to kick the process off. And I think we just need to build, you know, Manchester, Leeds, Liverpool, Glasgow, Cardiff, London, Southampton, Bristol, Oxford, Cambridge. We need to build this network of trial centres, which in kidney cancer has been a bit eroded over the last 5 or 10 years, speaking frankly. And I think and patients have got a role to play in this, a really important role, because there is a lot of, you know, there's a lot of genuine concern from a patient perspective in the community now that trial availability is not what it was 5 or 10 years ago. And it's possible now to be in the Manchester area without, you know, without a trial, which was unthinkable, you know, 10, 15 years ago, 10 years ago. I think, so I think this is, you know, I'm struggling my words a bit because it's such an important issue, but I need to choose my words very carefully because I don't want to be, and I'm actually not critical of, you know, I'm most critical of the process that has eroded the support for trials in the big cancer centres. Because when I phone my friends up and say, what about this and why are we not recruiting well, many say, well, you know, it's just been really hard. We haven't got the nurses we had 5 or 10 years ago. And why isn't there a strong cancer centre in Northern Ireland doing kidney cancer studies? You know, what is the answer to that question? And I know it's not the doctors, because they phone me up saying, Tom, how do we make it work? And they're trying to bring talented doctors across to do that work. So it's not a criticism of the hospital. The UK has got a bit lost in clinical trials, in my opinion.
That's a wonderful answer, Tom. Thank you. I've got a few more questions. Is that okay?
Yes, of course.
You're a star, Tom. Really appreciate it. Okay. Can someone be re-challenged with immunotherapy after a break due to progression or side effects? And if so, how long can the gap be, please?
So, I mean, the gap can be a lot. The gap's it's as long as you want it to be. I don't know how long the NHS allows that, but
yeah.
but I've re-challenged 6 months later. You know, I had a patient, we gave drugs, they developed kidney toxicity. We had to stop the drugs. We gave steroids for 3 or 4 months. The creatinine kept going up, kept going down. Eventually we had a 6-month delay. So, but, you know, and the cancer didn't grow during that period of time. Clearly you can't re-challenge if the cancer's growing, you've still got the toxicity, and that's a problem. And that's not an infrequent occurrence. So that's the first thing. The second thing is it depends on the degree of the toxicity. This is part of the clinical skill, and there is a clinical skill here. It's possible, you know, I would retreat with a grade 3 liver tox pattern, and I, you know, and I'm not clear. I'm not clear that, you know, one of the things I said about going to a centre that's treated a lot of patients, good support, good network. Number one is, if you've got a good support, you don't get bad toxicity, because you phone up and you get early intervention with immune therapy is crucial, because if you let it drifts off, it goes in the wrong direction, it's too late. And that's why it's crucial, number one. And then number two is that many centres stop at quite minor toxicity, which you don't have to do. You can re-challenge and do it safely, but you need to keep a super close eye on those patients, but particularly if it's working. So that's one like sunitinib, where actually it's quite easy. if you give it to patients, patients know when they get ill on sunitinib. They say, I can't take the drug anymore, and they stop. Whereas immune therapy is very different from that. And therefore, the medical skill is much higher. And that's why being in a centre that has experience, and that doesn't necessarily mean Manchester. You know, Torbay may be a much better service than, I don't mind, it's a fantastic service, but Torbay may be the best service in the country. They may have the best CNSs there. They may have the most experience, not a doctor who's treating 10 patients a year. They may have terrific audit data. And, you know, there's no reason why a modest-sized centre couldn't be the best in the country. But it's also possible that that doctor who's treating all of urology cancer and only seeing 2 kidney cancer patients a year, and their CNSs don't do kidney cancer, and that would be a less good service, and that would worry me. So patients asking questions about the service, asking about the audit data to make sure that they've got, you know, in a practice which is busy, that's really important for me. And also, as I said before, particularly, I mean, we've got some frontline trials coming up in the near future. We've got some second-line trials coming up, and some of those trials will be testing other immune therapies which haven't been tested previously. So I think, for me, that's how I look at the kidney cancer problem at the moment.
Thank you. You've got about 3 questions.
Let's do those 3 questions.
You're a star, Tom. Okay, you answered my previous question around the next treatment potentially being the trial with the HIF inhibitor versus everolimus, but I live in Northern Ireland and I don't have access to this trial. Would my next treatment be everolimus? Also, what is your opinion on everolimus versus envatinib, everolimus combination? As a reminder, my previous treatments have been sunitinib, ipi, and nivo, and cabo. Quite a long question.
Yeah. So lenvatinib everolimus is a choice. You know, it's a choice out there. And you know what? If you ask 100 people, 100 doctors, would I go with lenvatinib everolimus or everolimus? I think more than half of them would say go with the combination. Okay, entirely reasonable. I mean, everolimus is okay by itself. And you've had a lot of VEGF TKIs before. Lenvatinib may not help. I would go with the combination, probably, all things being equal. But if you get everolimus by itself, it wouldn't be the end of the world.
Perfect. Thank you, Tom. I don't know if you can answer this question or not, if I'm honest, because it's more of an opinion. Brain tumour ablation is being conducted using a visual aids. As far as we are aware, this is only available privately at the Harley Street. Despite lots of searching, we've only been able to find very limited information on this treatment, and wondered if you could point in the right direction to help find out how successful it is or not. And is this type of surgery, and what conditions should it be considered?
It's basically neurosurgical laser ablation. It's probably no better than I wouldn't get too caught up on it.
Okay.
So it's not the most important decision you're going to make. I think that it's involved in, it's not been any more proven, it's not been at all proven in kidney cancer or indeed other cancers. I can see why there are attractive components to it. We know surgery for kidney cancer, brain metastasis is not spectacularly successful. And we know that radiotherapy has its limitations. I think laser-guided neurosurgery techniques, I can see it being an interesting area. I can see it being technically difficult. And I can see why lots of people don't do it. I don't think there's any proof it's any better than doing SABRE or standard surgery. I can see there being a lot of hype and marketing around it. I can see it being super expensive. It probably won't do any harm. And if you said to me, would you want that or a good neurosurgeon, I'd probably say a good neurosurgeon, speaking frankly at this stage. Again, it's not something which I'd be 100% focused on. I'd be more focused on saying, you know, is treatment for my brain lesion the right treatment, or should I have systemic therapy? Number one. And number two is, what are the standard brain treatments and how effective are they? This won't be 100% better than anything else. It probably isn't worse. But we don't know that.
Thank you so much. Another question, if you've got time, Tom. Mm-hmm. If a patient had severe side effects from immunotherapy treatment, e.g. grade 4 hepatitis from the ipi-nivo combination, what is the advice around further immunotherapy treatment at any time in the future? Is there any research around the side effects from one immunotherapy drug or combination reoccurring with a different immunotherapy drug?
Yeah, that's interesting. So if you had ipi-nivo and you had toxicity on ipi-nivo, you probably won't get that if you just give nivo. So the combination is associated with more toxicity. If you had life-threatening toxicity with single agent nivolumab, I wouldn't re-challenge with that or any other immune therapy. If you had life-threatening toxicity with the combination, then there's a really complex consent process. But if it was just a grade 3 transaminitis and you had it stopped, or a grade 2 skin rash, you know, it might happen again, but then you will know what it is and you can manage it more easily. Start steroids a bit earlier, keep a close eye on it, you know. So life-threatening toxicity is more complicated, but if it's significant toxicity but manageable and you haven't had a good go at immune therapy, particularly if it was ipi-nivo, subsequent nivo would almost certainly be okay.
Perfect. Thank you so much. And the final question, which is quite a nice question to summarise it with. What is the most promising research in treatment of metastatic kidney cancer?
2 trials I'm really interested in, 3 areas actually. Number 1, this Cabo ipi-nivo triplet trial.
Okay.
So that's Cosmic 313. Those results are coming out soon. There are other frontline triplet trials coming out soon as well.
Perfect.
Number 2, the HIF inhibitor is an area of exciting research. And then number 3 is there's some exciting work going on with biomarkers to predict patients for therapy.
Perfect. Thank you. Has anybody else got any more questions for Tom, or did you want to say anything else, Tom? It's been so wonderful. I've learned so much.
It's been a real pleasure. No, just to say, I'd like to I'd like to try and broadcast our trials to you, and I'd like to come back one day and talk about adjuvant therapy, which is changing. There's going to be an adjuvant study at ASCO this year, I think, or the not too distant future, which is going to be positive for progression-free survival, which may change things. So yeah, I'd love to come back, and would like to broadcast what we're doing to you guys, to give you those opportunities if you wanted to, and in terms of clinical trials.
Wonderful. Tom, honestly, you are always so welcome. I've got a great idea, which I'll talk to you about off camera now, for other things you said today. There's a patient that wants to talk. Is that okay, Tom? Yes. Hello, Ali. Go for it.
Sorry, Tom, I'm the patient from Northern Ireland, as you can probably guess from my accent. So I was just wondering, did that last question, or what the penultimate question there was mine also around the ipi-nivo. So I had grade 4 hepatitis. And it's just whenever you said there about whether it was life-threatening or not. So I'm not sure if it was life-threatening or not, but my ALT and AST were sort of over 1,000, and it wasn't rectified with steroids alone. I needed a drug called Cellcept as well. And because of that, my team are now reluctant to give me immunotherapy again, because it was such a severe reaction. So that's why I was just asking sort of your opinion on
Did it work?
Nivo further down the line on its own.
Did you respond?
With the Cellcept and the
No, did you respond to the drug? Did the cancer get smaller with the ipi-nivo?
Well, I just had the first 4 doses, and I had stability in my lungs at that point. And that was all I had at that point. It was only because then I was taken off it, and then in the preceding months, or after that, then that was whenever my single liver met then appeared, but it was a few months later when I was off treatment altogether.
It's a really difficult call, Arlene.
I know.
To be honest, I mean, it's a really difficult call. I understand exactly where they're coming from. It was that's going to grade 4 is serious, and if it's 1,000, it's potentially life-threatening. In the randomized trials, we haven't seen many deaths in the thousands of patients we've treated. I think, you know, in some of those trials there have been no deaths, but we wouldn't have retreated you with more immune therapy. And so I think that they are being sensibly cautious.
Yeah.
And I think it probably is the wrong thing to do. If you come back to them and say, listen, I just want it, and I know the problems, but I've got a serious cancer, and I don't think we've given this a fair crack of the whip, they may come back and say, well, you didn't have a great response to the immune therapy the first time. And so if you had immune combination therapy and it wasn't great the first time, why do you think single agent immune therapy is going to be miraculous now, number one? And number two is we know it might be life-threatening too. So it's not going to make it melt away, number one. And number two is it's potentially dangerous. So under those circumstances, I can see the balance tipping towards let's err on the side of caution. Now, if you come back to them and say, listen, I want to take this risk, I'm really up for it, and we'll do liver function tests every week, and if I go to grade 1, we'll stop, and under that you can have that discussion, and I would entertain that. But I've got to say, I agree with them as it currently stands. Okay. Do I think I could give it to you safely? To be honest, Arlene, I don't know. I don't know. I think it's super tough. I've got respect for their position.
Absolutely. Yeah, and I totally understand where they're coming from. I think it's just because I feel like sometimes your options may be running out, because that was also my question. I'm on 3rd line treatment now with Cabo, and it just sort of feels that all of the success, it seems to be around immunotherapy. And if it's ruled out completely, it just feels a bit, ooh, what does the future hold, Johnny,
I don't know if you're allowed to have it, because you've had it before. You might not be allowed. You might need to, and that's complicated, because if they said, listen, we can't give it to you, even if we could, we can't do it. You've had it before, and we can't give Nevo after Ipi-Nevo, and you might be in that position. And I'm not that good at the NHS algorithms and pathways, and so there's no point in having the debate if you can't get it, because that's just super frustrating. So you might want to go to them and say, listen, I want to know if I can have it, because if you said to me it's off the table, that kind of solves the problem. And it's not one of those things that I'd sort of mortgage my house for as it currently stands. I know that sounds extreme, but I sometimes have those sorts of conversations with people, because this is pretty great. If the Ipi-Nevo made the cancer melt away and go from big to small or disappear, then I'd say, well, what you got to lose. But you didn't have that. You had 2 drugs, not 1, and the cancer is now different from what it was before, and is probably more resistant.
Right. Okay.
Thank you, Tom. Tom, is another patient that'd like to ask a question, if that's okay.
Hi there. Okay, I asked a question earlier, Tom. I'm saying that I was on Sunifred first for my first line of treatment, but it didn't agree with me, and I ended up in hospital. So then they put me on a low dose of PAS, which I've been on for 4 years now. But my last scan showed growth in my primary kidney, where the tumor is, and then I got 4 mets in my pancreas. And you said, why couldn't I have nephrectomy? But I've only got 1 kidney. I've already had the nephrectomy in 2000.
Yeah, okay, that's complicated. I see that, Alison. I mean, I don't know. There's it depends on where it is, and there may be an opportunity to ablate that area. Sometimes you can freeze these cancers.
Yes, it is actually on the edge of my kidney, but they said that they couldn't do it because it makes the pancreas ones go wild or something. That was a while back they told me that, so I'm not quite sure.
I'll ask that question. Ask that question again.
Okay, I will. Okay.
Doing the primary cancer won't affect the pancreas metastasis. As I said before, patients with pancreas metastasis have the best outcome.
Yeah,
so you're in a good position there, and that's why I'd be quite keen to try and focus on that primary kidney cancer a little bit.
Okay, lovely.
It may not be possible, but let's see.
Yeah, I'll ask the question. Thank you.
Thank you, Alison. Tom, this is a comment. Thank you so much, Tom, for all this excellent information, and thank you to Lucy and KCUK for putting this together. I find these kinds of presentations very helpful and very informative, and I look forward to more of them in the future. So thank you.
Thank you very much, and thank you for all the fantastic questions. It was perhaps one of the most interactive sessions I've had since the beginning of the lockdown. I really enjoyed it.
Oh, brilliant. Oh, you've got another question now, Tom. It doesn't stop, does it? Thank you. Okay. I had a great response to Ipi-Nevo, but developed G2 colitis after 7 weeks, so treatment was stopped. Cabo is holding my disease stable. So should I be thinking about that immunotherapy is the solution?
I think it's complicated, and I think going back to your doctors and saying, can I have immune therapy? Because if you responded initially and you've had a grade 2 colitis, Grade 2 colitis is, you know, if you treat through grade 2 colitis, you can get into trouble. But grade 2 colitis I'd put as a sort of a moderate adverse event, and isn't necessarily life-threatening in the same way as transaminitis of 1,000 might be. And under those circumstances, because you had responded to therapy, you know, you might say, can I give, you know, should I give it another crack of the whip with immune therapy if I'm exhausting other options? And that's a reasonable question. I don't know from an NHS perspective if you're allowed to re-challenge, and that's an important question, number one. Number two is, the other thing is, have you had all the benefits? How long do you need immune therapy for? And that's a question we've not answered. And is 4 cycles of ipi/nivo enough? Is that re-education of your immune system enough to last years and years? And it might be. And do you need to keep going back to immune therapy, or is one go at it with your tumor right at the start? With it it might be, and we don't know this, it might be that 4 cycles of ipi/nivo right at the start, and then no more immune therapy ever, might be as good as all of the other combinations and permutations of immune therapy. We keep going until progression, but do we need to do that, and why do we do that? And so that is quite a complicated issue. But it sounds to me that you did quite well with immune therapy initially. You've stopped because of a toxicity which I think could potentially be managed. Is it worth a second go? And I think that's worth a discussion with your doctors. I don't know if it's feasible in the context of the NHS. Again, it's experimental and it's off-piste, in as much as it's not been proven. And so people say, well, let's target the VEGF sequences first, which I totally understand why they've gone into Cabo, which is exactly the right treatment. So you're having exactly the right treatment, but is it something that you should flag up and say, you know, where are we with this? Yeah, that's reasonable. And I think if they come back and say, well, you had toxicity, I think it's reasonable to come back and say, well, yeah, I did, but I think I probably, you know, I'm prepared to take that risk a second time. And there's no evidence the toxicity will be worse next time. There's no predisposition when you re-challenge to get worse toxicity.
I think that's all the questions. I just wanted to say a huge thank you to also, because you do so much work behind the background to support our charity. And I know personally how much all the patients have valued this today. So it's a sincere thank you for everything you do as well.
Thank you. And thank you for those fantastic questions, and good luck to everyone on the call. And I hope that the treatments go well, and do reach out to me if I can help.
You're a star. Thank you.
Thank you.